So welcome to today's CPC Connecting Generations webinar. Today's speaker is Joseph Harrison, who's a research fellow at the School of Health and Social Policy. Many of you will know Joe from his time in St Andrews, where he completed his PhD, which focused on health and family trajectories of Pakistani migrants and their descendants in the UK and Norway, before he joined the Migrant Life Project. Joe is now a postdoc researcher at the University of Salford, working on the Paramore project, which studies immigrant morbidity-mortality paradox and aims to establish the mechanisms behind and consequences of whether migrants are living longer lives in worse health compared to non-migrants. And today, Joe will be presenting some of the early findings from the project, looking at the disease and causes of death contributing to the migrant morbidity-mortality paradox findings from the Swedish registers. So I'll hand over to Joe now to get started.
Thank you, Sarah. So yes, thank you everyone for coming. It's like a little homecoming. Very happy to be here presenting. So unlike a lot of other CPC seminars, which take a very cohesive approach to a large body of work, because I'm relatively new to this job, I don't have a large body of work, but when I was asked to present, I definitely wanted to. So I have put together a presentation more in sort of a conference style. So it'll probably only take about 20 minutes and it's still work in progress. So I'm hopeful some of you will have lots of comments and feedback and suggestions. So I work at the University of Salford in this Paramore project about migrant morbidity and mortality. As Sarah said, the project looks at the mechanisms behind and the ramifications of that. This paper and study looks more at the mechanisms because we're interested in identifying the diseases and causes of death that are a part of this paradox. So it is well established across immigrant literature on health that they live longer, higher life expectancies, lower mortality in general. But what has also been found is increasing heterogeneity amongst the health status of immigrants. Often they're found to have more multimorbidity, higher incidence of certain diseases, particularly cancers related to infections, higher rates of poor self-reported health, and higher levels of limiting illness and disability. This isn't for all immigrant groups, it varies across contexts, but there is definitely finding that some migrants are in worse health, but they are still living longer. And this is what has born this morbidity-mortality paradox that this project investigates. So why is this paradox important? Well, firstly, it's important for individuals who are suffering it. People would like to live a long and healthy quality of life. That is a pretty normal expectation that people have and a desire. So we want to know, we want to make sure that people are. It has ramifications in the healthcare and welfare systems. If you are sicker longer from an economic perspective, you do cost more, you're likely to leave the labour force earlier, and then that it has negative implications for the public purses, let's say. This also impacts the wider population health as we're measuring prevalence of diseases and overall frailty in the population. If people are living longer in worse health, this has implications there. As I say, it comes with a financial cost for society, lost tax revenue, these sort of macro level factors. And they also represent social inequalities and health inequalities in society that ideally we would like to equalize. So previous literature in this sort of area very rarely uses micro-level longitudinal data because that data is hard to get hold of and it's hard to use to look at both incidence of diseases and health measures and also mortality. So you have surveys, for example, SHARE, where you can do some longitudinal things, but because they're surveys, getting representativeness of mortality is difficult because they die and they disappear. What we have found amongst the paradox literature is it exists for certain groups in countries such as England and Wales, France, Australia, and it's typically found in countries from less developed areas of the world, origin countries, that is. But they are mainly using self-reported measures of health and morbidity. So the England and Wales literature often refers to the census questions and looks at reports of self-rated health or reports of disability within the census. So no one is really focusing on specific conditions or using data objectively from doctors and diagnoses. And that's what we're trying to do here. We want to look if this paradox extends beyond self-reported measures and into diagnosed conditions. And doing that, we hope will unveil more about what drives this paradox specifically, rather than relying on the conceptualization of health that immigrants have, which may differ from natives. So this study uses the Swedish registers. We use a collection of registers from across. We use the RTB, which is the main recorded register, which covers things like country of origin, your arrival date in the country, obviously date of birth, links into the marital status too. We have a register specifically for cause of death. Here we use the ICD-10 codes to define cause of death. And then we use a few more registers, the patient registers. This is a set of 2 registers, one which looks at inpatients and one which looks at outpatients. So these are people hospitalized, whether it be an overnight stay or a scheduled procedure in a hospital as an inpatient, or an outpatient. We have these from 1997, but the complete coverage of these starts a bit later, and that factors into why we choose certain timings of the study. We have a longitudinal institute register called LISA, which is where we get education and socioeconomic quintiles of the population. And then lastly, we use a drug register, which is where prescription drugs are recorded and reported. They come with ATC codes. Sorry. And it's those ATC codes that we can use for prescription medication, and we can use that to identify certain chronic conditions, which we use later. In this study, we're going to apply an illness-death framework. We use continuous time event history analysis, looking at a baseline of age. We study from over 40 onwards and apply Cox proportional hazard models. We use a long period of time. We use 2007 to 2019 as our at-risk observation time. 2019, we could extend further. We have data till 2023, but we choose 2019 to avoid the COVID complication because cause of death in that time may be a bit difficult to identify, and a lot of people are not diagnosed with COVID in hospitals, so we can't study that as a disease. We have to apply this sort of sweep period before entry because we don't actually know when people were diagnosed with illnesses prior to this date. So if people are entering the country with a diagnosis, we use the first 2 years after immigration to sort of establish this is what this person has. This is what is wrong with them. But for the native population and anyone who migrated before 2007, we use the period between 2005 and 2007. 2005 being the first year that we have full data across all the registers that we're using. We exit people at death, obviously, and also their first emigration, and you cannot return after you have emigrated once. Oh, sorry. Got a bit of a cough now, because I mentioned COVID, I'm sure. So we're using the top 10 causes of death in Sweden. We don't use them all, but here are the 11 top 10 causes of death in Sweden. That sounds strange, but it's because breast and prostate cancer apply for men and women. The top set are the ones we're definitely going to use. So ischemic heart disease, chronic obstructive pulmonary disorder, which is respiratory diseases, stroke, lung cancer, and breast and prostate cancer, respectively. And there are the corresponding ICD codes. We're definitely not using COVID, we're definitely not using Alzheimer's, dementia, and we're definitely not using pancreatic cancer, mainly because the transition to death from pancreatic cancer is really high and really fast. Alzheimer's, dementia, it's too correlated with age, and some of the immigrant groups don't quite reach those ages. And COVID, like I mentioned, comes with the problem of it being overused as a cause of death, despite a lot of underlying conditions. So we wanted to avoid that complication for now. In the middle, we have colorectal cancer and hypertensive heart disease. These are we might use, we might not. Currently, the results I'm going to show include colorectal cancer, but hypertensive heart disease may be interesting to include, and I'll show you why later, because of the other conditions. Cancers aren't as interesting, essentially, is the TLDR of that. But colorectal cancer is what we've included for now. For each group, we run 2 models. For each disease, we look from a period of having no disease, which I may refer to as healthy, but it doesn't necessarily mean healthy. It means not diagnosed with that disease. And from there, we follow people to a disease incidence, and then we model that with a Cox model. And then we model from disease incidence to death from that disease. And that death from that disease has to be the main cause of death reported in the cause of death register. We have done sensitivity analyses looking at whether it's an underlying cause in one of the other causes of death, or if it's or just using all-cause mortality too. So the interpretation of our results is if you have a high incidence of disease relative to natives, but also have low mortality after being diagnosed, we would have evidence of a morbidity-mortality paradox. We also would have evidence of an unhealthy immigrant effect if you have both high incidence and high mortality, the opposite being the case for low incidence and low mortality. That would suggest healthy immigrants don't get sick, and when they do get sick, they die slower or they get better. And then we have a unusual category, which would be very rare, which is rarely seen, which is having a low incidence of disease alongside high mortality when you get that disease. And this would sort of suggest you spend a larger proportion of your life spent healthy because you transition to death quicker despite getting sicker later in the life course. Across the models, we are using various control variables. We have fixed highest education. The models only start at age 40, so the education doesn't time vary much. So we just fixed it to save complications. The socioeconomic quintile, which time varies every year. Marital status, which can time vary every year. And then we have these chronic conditions, which we find through the drug register and the in and outpatient registers using ICD codes. So these are diabetes, a cancer diagnoses, respiratory conditions, and cardiovascular chronic conditions. Because these naturally correlate with some of the diseases, they aren't included when it's obviously that they shouldn't be. So we don't include cancer as a chronic condition covariate in the models that are looking at cancer. Likewise, we don't include respiratory for COPD, and we don't include cardiovascular for ischemic heart disease and stroke. So we had to make some quite arbitrary decisions. Like I said, the cause of death has to be the main cause of death in the models that I show. The sensitivity analyses around this didn't really show much difference across if it's a contributing cause or just any cause of death. But for the diagnoses, the ICD code can appear anywhere. So that means in this sweep period or any time after, let's say you have breast cancer, even if you went to the hospital with a broken arm, if breast cancer is recorded in your records, we take that date as your first appearance with breast cancer. And that's just to make sure we include things that are being treated outside of the hospital whenever we can. So if we know that the person's gone to hospital for something else, we don't distinguish that because we know they've got it. We don't want to lose that information. And then we only include people who enter healthy, meaning not diagnosed. So if you were diagnosed before the study period starts or in this sweep period, we don't study your transition to death. We want people who we know at the start when they were observed, they did not have this. We then follow them to getting it, and then if they get it, we follow them to death or not. And that was just to clean up any sort of hidden problems with not knowing how long people had diseases for. This is just some descriptives of the person time. So this is for men. I've highlighted some cells which have fewer than 10 causes, fewer than 10 deaths for different immigrant groups. It's mainly limited to COPD and hypertensive heart disease, and amongst Syrian migrants is where it appears multiple times. and that's because they're a newer group compared to some of the others and a bit younger, so there are less incidences and less deaths. And the same for women. For women, it's Chilean who appear a few times with few causes of death being studied. But again, COPD and hypertensive heart disease is where this appears. We're not too concerned about this. We're going to make a statement of like, oh, be careful. There's low numbers in certain groups, but the person years themselves are actually quite high despite low outcomes. So the results. The first figure is for men. So we've taken this sort of quadrant approach. Anything in this sort of top left quadrant would suggest the paradox. The top right would be high incidence and high mortality. So that would be unhealthy. Bottom left, this quadrant here would be healthy immigrant effect. And then this would be this more unusual quadrant. But as you can see, not many things appear in there and none of them appear doubly significant. So it's anything in blue is significant at 95% in both incidence and mortality. And the main sort of thing we can observe is it happens more in ischemic heart disease and COPD. Amongst the cancers, it's a lot more linear. Lung cancer, for example, there are no differences in mortality for any group. All the differences are limited to differences in incidence in terms of significance. And it's generally higher incidence, apart from Iranian men. The opposite is the case for prostate cancer. The Turkish are the only exception. They have low incidence and low mortality, but it's generally low incidence and no differences in mortality, which is the x-axis, so anything horizontally shifted. But for ischemic heart disease, we see these Middle Eastern groups, Iran, Iraq, Turkey, other MENA. Syria has the low numbers, which is why it's not significant in terms of mortality, but it is in this sort of cluster of showing the paradox evidence. The same is the case for COPD. It also includes, again, Syria, Iran, Turkey, the other Middle East and North Africa groups. Iraq also appears here, and Chile. But closer to the Swedes in the middle are the neighboring countries, Nordic countries, the other EU countries, former Yugoslavia, Germany. That is figures much more centrally around the Swedish norms. For stroke, this is what I consider quite interesting because we see it very clearly amongst ischemic heart disease, but we do not see it for other cardiovascular diseases like stroke. Here we actually see Iran is in this healthy quadrant. Iraq also low incidence, low mortality for Iraqi-born men in terms of stroke. Again, around the Swedes in the middle is the neighboring countries, sub-Saharan Africa, also there. Denmark, the only sort of exception where we see differences in mortality but not incidence. So you are equally likely to have a stroke if you're a Danish-born man in Sweden, but you are far less likely to die of a stroke following that first stroke. It won't kill you in the end. That can be good or bad depending on how people want to consider it. For women, it's similar. So the scales here are different because the women have a slightly different, they have a different spread of illnesses. But we see a similar sort of pattern. Iran, Iraq, Syria, other Middle East are in this cluster for ischemic heart disease. For COPD, not as clear. Turkey are in that cluster, as are Chile. Very low incidence for Chile, so maybe it's not a great example, but it is statistically significant. The same sort of pattern for stroke, much more centered around the middle and the Swedish behaviors. Again, though, Iran shows low incidence, low mortality, whereas for ischemic heart disease, it's high incidence and low mortality. For women, the cancers also mainly show differences across incidence. Colorectal cancer, almost exclusively only differences in incidence. Former Yugoslavia, an exception, lower incidence and lower mortality. German women, the same incidence but lower mortality following diagnoses of colorectal cancer. Lung cancer, This has large differences in incidence driven by the fact that a lot of these groups have very, very low smoking rates compared to Swedes. So the low incidence across the board for Iran, Iraq, Turkey, or the Middle East, Sub-Saharan Africa, Syria, almost half the risk of diagnoses of lung cancer for these groups, and differences in mortality still for Iranian and Iraqi women in Sweden with low incidence and low mortality. Breast cancer, much more condensed than lung cancer. And again, the countries closest to Sweden in the middle are nearby countries, so Denmark, Finland, Germany, the old EU, the original EU, and differences further out, although not significant, Syria and Iraq. Iranian women have a big survival advantage in mortality following breast cancer diagnoses, although they are getting breast cancer at the same rates. Various reasons that could be behind that, which we'll come to. I have included the hypertensive heart disease on a slide on its own to show that it isn't just stroke that's an exception. We also don't see a lot of variation across hypertensive heart disease in terms of the paradox. So for men, Iraqi men do show this paradox again, very, very low mortality despite higher incidence. But for women, there's no exceptions. No one showing this paradox. So it is just ischemic heart disease that we're seeing this paradox appearing. So there is discussion to be had around the impact of some of the decisions that were made. I chose 2 years for this washout period, the covariates I've used, and the main cause of death. However, I am fairly confident in the robustness of the results. We tried different lengths of washout periods, and what ends up happening is you just increase the likelihood. If you increase the washout period, you increase the likelihood of people migrating out, and also increase the likelihood of them just dying in that period, and then you lose out on numbers. But too short, and you don't capture people who have conditions, and then they transition very quickly because they are seeming to go in the second year of their migration. So that's why we chose 2. We tried robustness checks around different importances of the causes of death. So looking at if it's any contributing cause or just doing all-cause mortality. There could be some salmon bias that maybe people are migrating out, and that's decreasing the likelihood of death following diagnoses. But there is a lot of studies on salmon bias in Sweden using the registers and people getting diagnosed and leaving. And for the groups that we see the paradox, so these Middle Eastern groups most, they are the least likely to remigrate. Iranians have been settled for decades, and they're not going to go back for obvious reasons in current times as well. Differences in selection is something we want to get into more in probably a subsequent paper, and looking at differences between refugees and work visas and how they may have been selected differently on health characteristics. There could also be, this isn't popular with social scientists, but genetic differences in the propensity to be diagnosed with certain illnesses. We've seen it in UK literature around Black men and prostate cancer. So we believe this is part of the story, but it has unveiled a wider discussion about why it's ischemic heart disease and not other cardiovascular diseases. Because if it is things to do with lifestyle characteristics, it should be predicating other illnesses too that are related to the cardiovascular system, but it doesn't seem to be, which is why we then refer back to maybe it is some epigenetic mechanism. So our conclusions here. The paradox evidence is found for certain groups, the Middle Eastern groups, Iran, Iraq, Syria. It is mainly limited in ischemic heart disease and chronic obstructive pulmonary disorder. We do see differences in incidence across cancer, but not in mortality. And we think that's pretty well established in a lot of literatures, that you have different environmental factors and behaviors that affect your propensity to get cancer. But in high welfare state settings, such as Sweden, the treatment is good, or at least it equalizes people's risk of mortality after cancer. And our sort of vague conclusion is that because ischemic heart disease is the most common cause of death, It could just be that the paradox that we see across literature is due to differences in incidence and mortality of ischemic heart disease. And it might just be a factor of, well, this is what goes wrong in people's lives for immigrants and natives. They get ischemic heart disease and then they transition to death. And the difference between immigrants and natives in that is what drives differences in this paradox overall. So if you have any feedback on, these are ideas of feedback you can give me on how I presented the results, on these quadrant approaches, the washout period, how to handle some of the decisions I've made. I would love to hear what you have to say. But thank you. And because it's Easter coming up, here is the dog tax for the day.